So I actually met him on the way in this morning. I've had the great pleasure to meet him before, but I've heard tremendous things about him and his program. Dr. Ivy is the medical officer, genetic service branch at the Maternal and Child Health Bureau over at HRSA, and he's going to talk to us a little about the program that he's doing, Dr. Ivy.
I'd like to thank everyone for being here today and allowing me to give you a brief explanation of our program at the Health Resources and Services Administration, or HRSA. Within our hemoglobinopathies programs, we do have two programs dealing with sickle cell disease. The Sickle Cell Disease Treatment Demonstration Program, and I don't know what happened. Oops. The Sickle Cell Disease Treatment Demonstration Program, and then the Sickle Cell Disease Newborn Screening Program. You've heard a little bit about both of those programs today, and you may hear a little more about them as the day goes on, because we do have several of the people that we work with here today presenting. So I'm going to do just a brief discussion of our program. The Health Resources and Services Administration Program is one of the programs in HHS, Health and Human Resources. We're America's healthcare safety net. So HRSA is the primary federal agency for improving access to health care. You hear a lot about NIH, and NIH focuses research. You hear the CDC, and theirs is mainly surveillance and studying disease prevalence. Well, we are really dealing with that access to care issue. How do we make sure that patients have access to the resources and to the providers that they need so that they may stay healthy? The Maternal and Child Health Bureau is one of the bureaus that is within HRSA. Other bureaus include the Bureau of Primary Health Care, which deals a lot with the community health network. But we're the Maternal and Child Health Bureau, and we provide leadership to improve the physical and mental health, safety, and well-being of the mothers and children health in the population. So this includes infants and children, but it also includes their families, including the father and children with special health care needs as well. And so as it was mentioned, I'm in the genetic services branch of the children with special health care needs. So we deal with children that have that special need that includes sickle cell disease, hemophilia, and other conditions. So the mission of the Division of Services for Children with Special Health Care Needs is really to provide national leadership to expand and strengthen access to a system of services for children and youth with special health care needs and their families as they grow and transition through life. So we don't actually do the actual work on the ground. Those are our grantees that we work with to try to figure out how do we create that infrastructure, that network of providers and network of services that will allow children and youth, as well as their mothers and fathers, to get access to the best care possible. So that really takes us stepping back and looking at how do we work with our partners. Those include the state government entities. Those include our grantees to really make this happen. And our vision is really to have optimal health and quality of life for all children and youth with special health care needs. So as we look at children and youth with special health care needs, we know that they are at at risk because of chronic physical, developmental, behavioral, or emotional conditions, and who they also require health and related services to really stay healthy. So when you look at, for example, sickle cell disease, we know that individuals with sickle cell disease do better when they have access to the services and when they have access to the medications they need early in life. So we have a newborn screening program that helps us to identify those patients. But it's also important to continue to provide those individuals with the resources they need as they go through life. And one of the things we're seeing now with sickle cell disease is that really creating or filling that void as they go into adulthood is one of the areas that we're trying to focus on in terms of how do we improve access to care for adults with sickle cell disease as well. It's important to recognize that sickle cell is really changing. We heard earlier today about an individual that has done extremely well despite having sickle cell disease. In June, we may have, and as far as I'm aware of, the first NBA basketball player with sickle cell disease, not sickle cell trait. I don't know if you heard of Billy Garrett Jr. He's a basketball player out of DePaul University, and he's predicted to actually go in the NBA draft this year. So it's really amazing how the changes that are occurring in sickle cell disease. But we have to realize that as these changes grow, as we have more individuals going from childhood to adult, we need to have the resources, we need to have that infrastructure that can really address their needs. So what we do with our hemoglobinopathies program, and I apologize, is that we have two programs that we really want to look at how do we help individuals establish medical homes and get comprehensive evidence-based care within those medical home models. I'm going to talk about our two programs, and the programs that we are really looking at is building that infrastructure for providers, but also using community health workers to help address the needs within the community where sickle cell patients live. So what is a medical home? That's the first question that we have to answer, because that term is used quite a bit, and it's important that we understand what a medical home is. A medical home doesn't apply to just one type of doctor. It's not just a primary care institution. It's an idea, or it's a concept where you build resources around the patient to allow them to get access to the services they need when they need them. So that includes having a personal provider. That personal provider can be a hematologist, can be a primary care provider, but it's someone that knows the patient very well and is able to then coordinate their care. It also includes having a provider-directed medical practice. So earlier we heard about community health workers. That is one element of a medical home, someone that can help coordinate. But you have also the social workers, you have the providers, you have an infrastructure that surrounds the patients to allow them to get the services they need when they need it. It's important to realize, though, that most sickle cell patients, they have a life or all sickle cell patients have a life outside of their disease. So, I would say that they're part-time patients. Most of the time, they're trying to live their lives. They're trying to have jobs. They're trying to support families. They're trying to buy homes. And so we have to realize that sickle cell is just one element of their life. There are other elements that we have to also deal with and focus with and understand as well in the communities. It also means that it's a coordinated and integrated healthcare system. So it allows healthcare to be a person to move, not only transitioning from pediatrics to adult, but also looking at other parts of the person's wellness. By full disclosure, I have sickle cell disease, and I'm a 45-year-old African-American male. If you didn't know that I have sickle cell disease, there are other healthcare risks that exist there as well. Being African-American male, I'm at risk of diabetes, I'm at risk of high blood pressure, I'm at risk of cancer. And so those problems need to be addressed just as much as the sickle cell problem, particularly as I continue to move out through the lifespan. So coordinated care means that we don't just focus on the sickle cell disease, we focus on a whole person orientation. We have to make sure that what we're doing, though, is high quality and that it's safe. So a medical home really focuses on that, making sure that quality occurs. So we have quality improvement initiatives to make sure that we can continue to advance and improve the care that we're delivering. And, of course, we want to make sure that we have enhanced access to care as well. So when we look at the six core systems of the children and youth with special health care needs, we see that it needs to be community-based. It needs to be where patients live. It was explained earlier that geography is very, very important. We can see that there's a dynamic, U.S. is very dynamic and changes occur all the time. We can see that changes are now occurring in our inner cities compared to our rural areas. As more socioeconomic lower individuals are moving away from the city centers and the higher socioeconomic classes are moving into the center city urban. So what will that mean for access to care for the sickle cell population if they're moving further out from the cities or if they're moving into the suburbs? How will the system change to allow individuals to continue to get access to care? early and continuous screening is very important. We identify individuals with sickle cell disease through newborn screening, but it's important that we continue to evaluate them and to screen them for other complications that may arise in sickle cell disease. That includes screening for stroke risk through transcranial Doppler. That includes screening for other complications that may occur in sickle cell disease. Access to a medical home. We want to make sure that all sickle cell patients have access to that medical home. And as I mentioned before, medical home doesn't apply to just one type of provider. It's that concept of building a system around the patients that will allow them to get the best care possible. Transition to adulthood. We've done an excellent job at identifying sickle cell disease early, getting babies on penicillin prophylaxis, and treating the children as they go up to adulthood. It's now that we start having to look at that transition from pediatric to adult care, because we realize that that there are complications that are occurring in that 18 to 35 year age range. So we have to turn our focus now to how do we help patients with sickle cell disease transition and to continue to have good quality of care. And then also having families as partners. We know that, as it was mentioned earlier, we don't want to do something if the community or if the patients don't want it. So we have to listen to that patient voice. We have to hear what the families are telling us, and we have to try to build a program that incorporates their ideas as well. So our program, the two programs that we have, the Sickle Cell Disease Newborn Screening Program and the Sickle Cell Disease Treatment Demonstration Program, we really use those two in the context of the chronic care model. And the chronic care model states that you get improved health outcomes when you have an informed, activated patient that's working in a proactive interaction with a prepared proactive practice team. And we know that there are influences that that are on those two groups, but we have to have at least those two elements in order to have successful outcomes. We need to have patients that are aware of their condition, that understand the steps that they need to take to stay healthy, and we need a prepared proactive practice team that's there with the knowledge to help those patients and give them the services that they need. So what we have done with our two programs is we really use the Sickle Cell Disease Newborn Screening Program to focus on that informed, activated patients. We use the community-based organizations, which you've heard from earlier, and community health workers to figure out where are the patients and how do we get them the knowledge they need to help assist them. How do we inform them of where the resources are, and then how do we move them into that medical home. But we also need providers that are willing to take the patients and to serve as their medical home. So we are working with the Sickle Cell Disease Treatment Demonstration Program to really create networks of providers to really get the education of what the guidelines are all about down to the patient level. As I go along, I'm going to talk mainly about hydroxyurea, but we want to focus on the entire guidelines. We want to do that, though, by first building a system that would allow providers to educate other providers about what's in the guidelines and how to use that information to best serve the patients. So with the Sickle Cell Disease Treatment Demonstration Program, as I mentioned earlier, this is a focus on the providers. How do we create or develop more knowledgeable providers that can then treat the sickle cell patients? We did fund with our last round 4 regions. Due to funding, we weren't able to fund more than 4 regions with our first round. And unfortunately, because it is a competitive process, we weren't able at the time to fund the South region. We know that the greatest need is in the South, and that was an oversight on our part in terms of how do we get resources down into the South. But we were able to fund 4 regions with our current effort. With our future effort, we are looking at expanding and then funding more of the country to use this model to really get care to the places that need it. But with this round, we were able to fund the Northeast, and you can see that each of our regions are multi-state regions. They cover 4 or more states. So we're not talking about an effort that's concentrated in one area around one major medical center. We're talking about an effort that involves multiple states that could potentially have a broader reach for the sickle cell population. The Northeast, you can see the states there, the Midwest, the Heartland, and the Pacific regions are our current grantees. To date, though, we've had quite a bit of success. We've been fortunate to really work with strong leaders in the sickle cell community to really try to figure out how do we go about making the situation better for individuals with sickle cell disease. And so, as I mentioned, we funded 4 regions, which include about half of the 100,000 sickle cell patients. So about 56,000 sickle cell patients are in the regions that we were able to fund. And our program directly touches, meaning our grant dollars directly touch at least 14%, or about 8,000 of those patients at this time. We hope that as our program continues to expand, we can increase that number to where eventually we're trying to touch at least 90% or more of the sickle cell patients. One region in particular, and unfortunately I can't talk about all of the regions here, but in the Pacific region, which you'll hear about in just a few minutes, they have shown particular progress. Between 2015 and 2016, the number of patients receiving care from their sites has increased by 36%. So they've been able to increase the number of patients that they're touching by 36%. And over the 3-year grant period so far, the number of patients on hydroxyurea in the Pacific region has increased by 26%. So I know those sound like small numbers. I don't know, maybe they do, maybe they don't. But we can really use this model to then try to figure out how do we increase the use of hydroxyurea? How do we increase the number of patients that have access to high quality care? One of the other things that, as it was mentioned, is very important is having the data, finding out where the sickle cell patients are and what's really happening with those patients. Our focus had been on Medicaid data, claims data, to determine how many patients there are in a given state and how many of those patients are taking hydroxyurea. And we've been fortunate enough to receive data from quite a few states. So you can see here in the Pacific region, there are several states that are submitting data. The Heartland has state Medicaid data. The Midwest has quite a few states with Medicaid data, and the Northeast. We have observed that there are some difficulties with working with claims data, but we see this as a win in that we are able to now learn a lot more about the sickle cell population. So as I mentioned earlier, with the next round of our grant, we hope, or we will rather, cover the entire U.S. with our grant portfolio. We will have a total of 5 regions. So we did expand the regions. They're the Northeast region, the Southeast region, the Midwest region, the Heartland and Southwest region, and the Pacific region to cover more states. And so what we will try to do is try to broaden these networks and make them so that we can eventually figure out how to get care to everyone in the U.S. I know that earlier it was discussed, and correctly so, that most sickle cell patients live within certain zip codes. But I think it's important, and me personally, and as a sickle cell patient, that we try to figure out how do we get high quality care to every sickle cell patient, no matter where they live. So even if they live in Idaho, we figure out how to get them care. Now, I know a lot of you are probably thinking, well, what sickle cell patients live in Idaho? Well, you'll be surprised, and then we have to also, as I said, look at the changing dynamics. We do have an influx of refugees coming into the country, and the government places quite a few of the Somali refugees in Idaho. So from what I understand, there are sickle cell patients in Idaho. So I do recognize that with limited resources, you have to figure out how to use those resources effectively. But I also would like to think that we could figure out how to make sure that if they're American, they can get access to sickle cell care living in the U.S. So our sickle cell program objectives for the next round is we will hope to increase by 10% the number of providers that are participating in our telementoring and telemedicine program, and I'll explain that in just a minute. Increase by 10% the number of providers that are using treatment and prevention recommendations. So we want to work with ASH, the American Society of Hematology, to figure out how to increase the number of providers that are using the guidelines, increase the number of providers that are on hydroxyurea, increase the number of patients that have access to pneumococcal vaccinations, increase the number of patients that are getting the transcranial ultrasound. And so we hope that we can do all of this with our program. So I mentioned earlier telementoring and telemedicine. And so one of the things that we're looking at with telementoring is called Project ECHO, Extension of Community Healthcare Outcomes. This is a system that was developed in New Mexico to really improve outreach use around liver disease. And what it states is that you have a specialist, in our case a hematologist, that's then able to reach out and provide knowledge and education to primary care providers so that we can get a broader reach to the sickle cell population with our providers. So that's the sickle cell disease. And lastly, this is an example of one of our Project Echoes. So the Midwest is actually using this, and you can see that they now have, they're using a system, and it's allowing them to touch providers within all of the states in their region. So you can see even in Minneapolis, they have providers that are participating in their Project Echo. In Milwaukee, in Peoria. So some of these areas that we would say, okay, well, this is where we need to get the knowledge, we're trying to use Project Echo to really figure out how to continue to educate providers on sickle cell disease. So now moving to the sickle cell disease newborn screening program, follow-up program. With this program, what we hope to do is provide support to a national organization that can then work with community-based organizations to improve the care of individuals with sickle cell disease and sickle cell trait through education and service coordination. So our focus on the sickle cell disease newborn screening program is really building that capacity of the community-based organizations. And that will allow us then to build that network that can really touch patients. So we hope to train community health workers. We increase partnerships that the community-based organizations have, and then we will assist the community-based organizations in really helping to fill that void to help patients get into those medical homes. So that's my presentation. I hope that you enjoyed it, and I think we'll be around for questions, but thank you.
This session is getting real interesting. I am now your moderator. Unfortunately, I do not have the bios, so if you don't mind, Dr. Nugent.
Happy to.
Thank you.
And I'll be brief. Hello, everyone. I really want to thank the organizers for giving us an opportunity to participate. One of the things that we already know just from this morning and from yesterday is that we are small in numbers, but network and community advocacy is going to change this. And you've heard, and we all know about the power of what our centers are doing. And I just want to really make sure that you leave here with a couple, 2 or 3 new concepts or concepts to stress that I think are critically important for moving the benchmark for our adult sickle cell patients who are currently not receiving adequate care. So you notice I changed mine to integrated sickle cell care models, outpatient community-based clinics. We don't need to talk about inpatient integrated care if we're doing the right thing in the outpatient setting. In the next 20 years, we should have all of our patients on therapies that would prevent sickling, would prevent hospitalization, and indeed cure patients. I'm giving you my take-home messages now. The other thing is, although we talk about the care that we give, we are absolutely not going to be able to propagate it unless we change our business model. This is something nobody has talked about here yet, and I don't see it coming on the agenda, but you cannot leave here today without understanding that we're not going to change adult care unless we change the way we pay for care in this country. And there's a lot of options there. We're in the place where they're talking a lot about it, but we, the small group of this band of brothers that's in this room, needs to change that, or we're not going to, we'll end up having this meeting 5 years from now and talking about the same doggone thing. So those are messages that I want you to leave here with, and after I give this talk, and I was in the back shuffling side, so hopefully this will be shorter than my original talk, but the main messages, I hope that you can leave here today with those. Okay, now I'm going to go through what all the other previous speakers just did. It is a touchy button. Okay, so my life in sickle cell began really with my fellowship training with Jack Githens in Denver, Colorado. If those of you who are old enough to know Jack, he trained Peter Lane, he trained a lot of really the sickle cell leadership that has been around for the last quarter of a century. And I left Denver as a resident to go do my fellowship in Seattle. And when I was in Seattle, there was no one really doing sickle cell, so I was asked to take care of the patients there. It was a large group of patients, but one thing that was obvious in Seattle was that this wonderful, beautiful children's hospital was located in Laurelhurst, which is the richest community in Seattle, and our patients were not coming to sickle cell clinic because they had to connect through 2 buses, and it was just not easy for them to go to a hospital that they associated with illness to receive their care. So I approached Blanche Levizo. I really think she was a trailblazer for primary medical home. She had a wonderful clinic called Odessa Brown Clinic in Seattle, and I approached her and said, I'd like to hold our sickle cell clinics here rather than up at Seattle Children's Hospital. She was phenomenal. This was the first time that people had actually started delivering integrated, comprehensive care in a community-based clinic. And to this day, I believe that this is what's going to change what we do in sickle cell. We have to take it out of the hospital footprint, which is extremely expensive. It's a place where none of our patients want to go for their care. Why would you go to a hospital to get your primary sickle cell outpatient care? And Blanche was really helpful in helping me get that set up. That has continued. Mark Walters took it over after I moved, and now Bender, who many of you know, a wonderful advocate in sickle cell disease, continues that clinic in Odessa Brown. Challenges that he has right now is that the community, as Donnell mentioned, and as many other people have talked about, the community has shifted. Seattle is the home of Microsoft, not Amazon, but a lot of these big places. The area where that clinic was initially built in South Seattle is now gentrified, and the community that really needs it the most, as you heard, the majority of our patients are below a certain income. They can't afford to live around Odessa Brown anymore. We have to address these economic factors in order for our patients to get care. Now, this is pediatric care, and most of our families actually prefer a community-based clinic setting. I thought it was all about transportation at that time. I've now learned after 20, 30 years that in fact, all of us want to go to an office setting for our outpatient care. The hospital's associated with pain, with significant disease, lung crisis, splenic crisis, as Jeff mentioned before. Why would we want to go to that setting for our outpatient preventative care? So patients taught me right away that it's not the hospital that they want to go. And that was part of the problem. It wasn't just all those bus transfers. They had ownership of this clinic. It was in their community. Community health workers are associated. You can do better preventive care if you're in your own community. Your vaccines, all of your health care is delivered in an area where they know about sickle cell. And I don't need to mention how cost effective it is. The overhead for a hospital clinic, you get charged per patient, the same room, it's hundreds of dollars as compared to the clinic in the community. Now, this is the NIH recent slide, which is fantastic history of what we can do. I'm not sure where that pointer goes, but in any case, I can talk you through it, of the great advances in life and survival. You've been hearing this throughout our meeting today, and it is truly a wonderful thing that we've gone from when I started of this being purely a pediatric disease. Nobody lived longer than 18 years. Life expectancy we were all happy about was 14 years because we started using penicillin, then children were given vaccines, then hydroxyurea came, and now, as Dr. Thompson said, 95% of children are surviving to adulthood. So now what's happened? So when we said 95 children are surviving to adulthood, what happened to that curve suddenly? In 2006, all of a sudden we realized that the curve had flattened out. The momentum had stopped. It had totally stalled. And when that announcement came out, 95% of children live 21 years of age. From that time to the present, children that were born in that year are currently 21 years of age. I can guarantee you they have no place to transition to for the majority of those patients. We look a lot at what's happening to children that are staying in their center of excellence. There are very, very few sites where that excellence in care is continuing. What's happening, as you've heard too, is that there is increased utilization when kids leave their medical home, their sickle cell center as children. Many of them resort to going to the ER and hospitalization. So if we look at this curve, maybe this is the impact of an absent system of integrated healthcare. When you leave as a child and you go out and there is no network of care, what happens in the US? It's flatline. What happens in UK, where there is organized care, or in our centers where there is an integrated healthcare delivery system? You know, that line, it may dip a little, but at least it's still going up. In the UK, the survival is right around late 50s to 60s, in some centers, 70. In Southern California, where we had no network of care, as Mary mentioned, the last center closed when Cage retired. In some areas, it's dropped to 29 years of age. Kim Smith-Whitley and I had a conversation about 4 years ago about this, and I said, this is your AIDS epidemic. This is what happened to hemophilia. Suddenly, in the early 80s, the hemophilia treatment network emerged out of nowhere because of AIDS. There was comprehensive care in hemophilia, but now we have over 132 HTCs, hemophilia treatment centers. It was built on HRSA grants. It was built on CDC grants. If we don't see this as being the AIDS epidemic, in a sense, for sickle cell, that we can do such a great job that 95% of the kids are on track, and suddenly now in Southern California, it's 29 to 30 years. We are blind to what's going on in this country. And let me just say that it is not just an issue of the fact that our patients are perhaps not living in areas where they have optimal diets, where they can get access to health care. It is, in fact, a phenomenon that occurred and was first described in 1992. You know, when I was working with Jack Githens, and when I went to Seattle in the 80s, we had 148 centers where sickle cell patients could go to in the United States. They were called medical schools and teaching hospitals. There was no insurance issues. Those patients could go directly there because it was critically important for medical schools and teaching hospitals to train physicians how to take care of patients with rare disorders. Sickle cell is 3 or 4 times more common than hemophilia. We had full clinics with sickle cell. We knew how to take care of sickle cell. The Sickle Cell Care Act from 1972, it taught us what we needed to do for as much as we could do at that time. But this changed everything. And when hospitals became corporate, when it no longer became cost effective to have chronic complex disease, not just sickle cell clinics closed, hemophilia clinics closed, cystic fibrosis clinic closed, because it is not cost effective in a healthcare plan, an HMO teaching hospital in this country, to care for patients with complex disease. This is a business model problem. And Jeff, I'm going to come to you. You're going to need to help us to teach our communities, to teach our country, that we can't have our teaching hospitals only seeing patients with heart disease, with diabetes and stroke, the common things that Kaiser Hospital has chosen to focus on. The teaching hospitals and education centers of our country was where complex chronic disease was bred and born. And we have totally lost that network of care. So when Cage's Center at USC closed, that was it. No more teaching hospitals. We're centers of excellence in Southern California. And it's not because the patients weren't there. It's not. It is a corporate model. And we need to face that industry and for-profit is running and dictating the care in our country. If we don't face that, we're not going to have centers for metabolic disease. We're not going to have centers for anything. It's not just race. It's not just poverty. It's corporate. So without that, centers of excellence for adults to go to, what happens? Well, already in 2004, the cost of hospitalization for adult sickle cell patients, $488 million in 2004. Paid for by who? Medicaid and Medicare. We're taxpayers in this room. We should be appalled at that number when we know that we can prevent hospitalizations and ER visits. Currently, Johns Hopkins researchers showed that $1 billion was paid for pain-related complications of sickle cell alone. It's just escalated. So it's true, our healthcare system has abandoned adult sickle cell patients. In our region, as Donnell kindly mentioned, and let me just say that our region, the Western, the Pacific states, we've had that success because we believe in network. When we applied for the grant 3-4 years ago, it was in collaboration with our co-PIs at Oakland Children's Hospital, specifically Marcia Treadwell, who has gotten all of our data together, along with Mike Rowland, and our other full partner, Mary Brown and the Sickle Cell Disease Foundation of California. We have to use these networks. Judith Baker, who's part of our team, is our policy person who's gotten us connected with many, many other groups, both federal and state, to help promote the goals and objectives of that HRSA grant. It wouldn't happen without all of those people. And that's why we were lucky enough to be as effective as we were. In California, close to 40 million people. We have somewhere around 7,000 patients with sickle cell. This is based on the work that Mary Houlihan and Susan have helped us with in the CDC, multiple databases. You can't just have one database with sickle cell. You have to put them all together. And that's what we learned in the last 3-4 years. Brousseau's data, Pelecanis data, the work that Mary presented this morning. And what we know for sure in California, and this is probably true in Texas as well, is that 10 to 12% of our patients are Hispanic. In my particular clinic in Orange County and the Inland Empire, 50% of our sickle cell patients are Hispanic. This creates huge problems because people don't understand that you can have sickle cell in patients outside of the African American community, and many mixed race now are coming through. So education and care for these patients who many times are neglected or their disease advances before we see them is really critical. So here is another stark fact about California. 60%, 2/3 of the population of California lives in the lower third of the county. This is why a lot of people enjoy living in the northern part of California. And this is excellent CDC data and also state data that Mary Brown, Susan Pelecanis, many of our colleagues have put together for us. This is the newborn data screening. This is where the number of newborns with sickle cell live. So in Orange County, we see a lot of the kids in San Bernardino and the Inland Empire, Riverside, and then the darkest blue there is the county of Los Angeles. And we estimate that in that county, we have around 3,000 sickle cell patients, and when the work was done in 2015, by the CDC, there were only 5 of us, hematologists, that were seeing adult patients. Huge problem. And as documented there, a much higher mortality rate than the rest of the country. This is where our CBO partners really came to the fore. One of our problems, we didn't know where the patients were. We didn't know who they were seeing, where they were getting their care. And so in collaboration with UCLA and the Sickle Cell Disease Foundation of California, who is contracted to do a lot of the newborn trait counseling, helped us identify where those patients were, what facilities they were using. And through this network of care, we were able to identify where we needed to put centers. You've heard about Martin Luther King, which was highly successful and really opened for business full on in October. To give you an idea of how rapidly that's growing, they've only been open for a few months. There are over 60 patients now. These are the sickest patients that I have ever seen or cared for. They have end-stage organ disease. They have not been followed. They're critically iron overloaded because they've been transfused. The resources that the county has made available to us once we made them aware of what was going on has been phenomenal. We're trying to grow as fast as we can to find services for red cell exchange and all the other things that these patients need. But it's a big success, and it's due to Mary Brown, Judith Baker, and our community support that we're getting there. And the community health workers program, which Mary has been working on and has been so very effective. So changing life expectancy in sickle cell disease, we can't just get registry information. It's important, but a lot of that information, as in our grant, is coming from the centers of excellence. We're the centers that are getting the grant, we're getting the numbers, and so it's not really reflective. We're only capturing, as Donnell showed, 10% of the patients in this country. 90% of the patients are not in a good medical home, are not in a serious, they're not having their needs addressed. And this is the really important thing to realize, is if we don't get a network of care, that 90% of patients are not going to have access to all the new treatment that is coming out. The pipelines and every pharmaceutical company that's supporting this today have sickle cell treatment that is just breaking right now, that should be available to patients. How are those patients going to get access to that? How are they going to get access to gene therapy? 90% of our patients are out of the loop. So this is, in closing, what I want to leave you with. I'm right on it, man. I've been practicing 3 minutes. It'll be done. This is the impact of network. The network itself is going to change that curve that I showed you before. Starting today, if we can create a network, patients will have access to all of those agents that are going to improve their quality of life and decrease health care costs. And in fact, cure, just like Sonia mentioned this morning, we're going for cure. And that gene therapy, gene editing is just, we're on the verge of that, but we have to create a network of care. And how's that network going to happen? We have to build our workforce. There's a reason that patients who are trying to transition are not finding a medical home. There's no hematologists. We don't even have physicians, family practitioners, and hospitalists. We have to build our workforce. Anyone who wants to see sickle cell patients, I don't care what their degree is or where they come from, we will pay your loans. Just like the Peace Corps, we have to have Sickle Cell Corps. Let's help get people into our communities, into our clinics to care for patients with sickle. They'll be hooked, just the way we are. But we need to get them there. And the way so many wonderful hematologists I've interviewed and tried to get into our center say, you know, I just can't pay off my loans. I can't pay off my loans for what we get paid to see sickle cell patients. And this is true for a lot of hematologists, benign hematologists. We need to change that. And there's work loan repayment for nurses, for social workers, for all of those individuals. We can get them into our clinics. We need to get bundled payments. We need to change the way we pay for sickle cell care, the totality of the care. Derek Robertson, one of our board members, Mary Brown, another board member, Randy Curtis, a board member, all of whom are in this room, sit with me and say, Diane, we shouldn't need 340B to pay for care, for sickle cell care in this country. And they've convinced me. But the way that we have to do that is change our model of care. And finally, if we decrease utilization, our state, our federal partners, our agencies will save a ton of money. And it will that savings will more than adequately cover the care. So I'll just close. All of these groups are our partners. Let's create a network again. Let's build it. It's what we got to do if we're going to move the mark. Thank you.
Hi, everybody. So I know almost everybody in the room. So I want to give everybody a challenge because we are somewhat speaking to the choir. If you know someone who doesn't know anything about sickle cell disease, my challenge to you when you leave today or tomorrow or in the airport, person sitting next to you on the plane is tell them about sickle cell. Because you'll be amazed at the people who've never heard of it. And those are the people that we really need to talk to. And I am going to say that I'm not Dr. Smith-Whitley, so if we could find the other slide set, that'd be cool. Also, I'm really glad you didn't read my bio, because if you had, you'd learn that I was an emergency medicine doctor at the University of Miami. I'm not. I'm Dr. Julie Kanter. I'm a hematologist, and I'm at the Medical University of South Carolina. I apparently have a doppelganger. I also want to talk about access to care, and I want to talk about access to care with a lot of what we've already sort of talked about with slightly different conclusions. So I like to start with a story because I feel like stories really bring things home. This is about a 28-year-old woman who lives in South Carolina. She lives in a small town called Loris. She has Medicaid. She's on disability. She doesn't have any children. She maybe saw a primary care doctor over a year ago, and she's unsure if she has ever seen a sickle cell specialist. She doesn't know when she first was diagnosed with sickle cell disease. She fell outside of when she would have been diagnosed by newborn screening. And she thinks maybe once she saw a hematologist. But she goes to the emergency room about 3 times a week due to extreme pain. She doesn't have any disease-modifying therapy. She gets some intermittent pain medication, and of course she's a drug seeker, because if you look at her profile, which we can all pull up now on the computer, you can see who's prescribed what. She has prescriptions from over 25 physicians. Unsurprisingly, because she has prescriptions from whoever is in the ER that day. And she gets transfused sort of whenever she gets admitted, and she's what I consider medically abused. She's fearful, she's hateful, she's spiteful. When I first met this lady, she came into my clinic cursing at us, yelling at us, and then eventually she got to trust me, and then she'd tell, nobody can see me but Dr. Kanter. Well, that was obviously a problem. About a year into her care with me, she was on the floor one day, hospitalized, and I went to see how she's doing. She says, you're going to be so proud of me. So what'd you do today? And she says, well, this nurse was being mean, and she wouldn't come help me. And I didn't yell, and I didn't shout. I just got up and went to the nurse's station and asked for help. And she recognized the difference in her own interactions that could help improve her care. I bring you up that patient because that's an example of over half the patients I've been seeing over the last 5 years. We've really looked at most of this information in terms of who our population that we're treating, and so I'm not really going to focus on that at this point. And we've also talked about mortality, realizing that while our children are surviving well into adulthood, in 2014, 66% of the deaths in sickle cell disease were occurring between 25 and 54 years of age. And the mean recent surveillance data that comes out of all the good work that CDC has done has shown a mean death of age 43 for women and 41 for men living with sickle cell disease. And I have a lot of beliefs about why these individuals with sickle cell disease are dying. Unfortunately, one is that it's a bad disease with a lot of complications, and if you're not getting managed appropriately, you're going to succumb to those complications. Number 2 is actually just bad doctors, or I should say unknowledgeable doctors, and doctors who don't know when they need to call for help, or don't know how to call for help. And the third is unfortunately bad behavior on the patient's part, and that can take the role of many different forms. Again, as we've talked about, the geographic distribution of Black and African Americans in the United States really mirrors the sickle cell population. There's the Hispanic distribution, and now we're looking at the distribution of the U.S. sickle cell disease population. And again, you can see a huge concentration down in my area in the southeast. This is one of my favorite graphs, and it's really what we should talk about when we talk about adults living with sickle cell disease. Dr. Nugent mentioned 5 providers in Los Angeles providing for adults with sickle cell disease. I'm one provider in Charleston, South Carolina, providing for adults with sickle cell disease on a routine basis. There's three in all of South Carolina, and we estimate about 4,000 affected individuals, and 3 doctors who care for adults living with this disease. So we have a long way to go. And you can see here by state, these are estimated numbers based on the Sickle Cell Adult Provider Network, just how few doctors are seeing individuals living with sickle cell disease past the age of 18. And as we've also talked about, as a result of this lack of availability of care, that forces individuals to use the emergency department more than maybe we would like them to or they would like to. And in 2013, there was over 315,000 ED visits. A lot of those were in metropolitan areas and teaching hospitals. And again, you can see the strongest concentration of those individuals living in the South. And 61% resulted in discharge rather than admission. And again, unsurprising, 74% of that greater than 315,000 were these young adults, these individuals living 18 to 44 years of age. Looking at the hospital care, you can see very similar trends with larger teaching hospitals and larger facilities in urban areas taking in most of the individuals. Again, the concentration in the South, and looking at a mean length of stay of 5 days at a cost of about $8,000. And there's a 0.25% in hospital mortality. And most adults, unfortunately, don't stay in the hospital 5 days, or they go back to the hospital if they leave after 5 days. And our length of stays have gotten longer as people have begun fearing readmission. So it doesn't necessarily mean the care has gotten better, but the individuals are staying in the hospital longer because the doctors are scared that they'll otherwise be readmitted. So when I first moved to South Carolina, now 4 years ago, I really wanted to get a sense of where were patients being treated. I'm from Louisiana, born and raised, but I've lived all over, St. Louis, Colorado, all over the place. And so when I came to South Carolina, I was shocked to see one of the biggest differences that I had seen from Denver or from St. Louis, that a lot of our individuals didn't live in the cities and in fact lived in the very rural areas. So down in the yellow is what we call the low country, the blue is the PD region, the red is the Midlands, and green is the upstate. And the largest concentration of patients is in the low country, but spread throughout the low country. And unless you're in Charleston, which is not a big, Washington, D.C. by any thought process, but it's our urban environment, you can still see that there's a lot of patients that fall outside this region. So we did this study when I first got there, looking at data from 2013. And kudos to South Carolina, we have an amazing data source that a lot of states don't have, where we can get all inpatient and emergency use care data from all the different insurances. So I can't get hydroxyurea use, but I can see who's been in the hospital and where they've been on an aggregate level, which is fairly amazing. And what we could see is that the majority of these acute care encounters were taking place in the low country, but what was amazing was the number of individuals being seen in the PD in very small community rural hospitals. There was at least 600 encounters. These are hospitals without a hematologist, many of whom don't really understand sickle cell disease and in fact still rely on counting the number of sickled cells on a peripheral blood smear, which is fairly useless. So it really tells you how little a lot of these individuals understood the disease in the areas in which they were being treated. You can also see, looking at this, and I'd be happy to show it to you in larger form if you'd like, that the expected payer tended to be Medicaid in the majority, but a large number of individuals were also on Medicaid, and then Medicare was secondary. We have about 35% of our individuals on Medicare. And again, you can see the biggest bulk of patients were in that young adult range. So then I wanted to see, well, let's check out this whole readmission thing. Is this readmission thing such a big deal? Yep, it is actually. So I know the graph is small, but on the days, on the x-axis, that's just 30 days. And on the y-axis is the rate of 30-day readmission. And what you can see is that over 70% of our young adults are readmitted within 30 days. Now, readmission is a little tricky in sickle cell disease. Sometimes it's readmission because they weren't sufficiently treated or taken care of on the first round. But sometimes they just get sick again, or they get a new fever or a new problem. So it can be very difficult to use readmission itself as a marker of quality. study. We broke this down and looked at 14-day readmission rates and found that that would be a more apt use of a quality marker, and even breaking it down to 7 days might be a little bit more beneficial in sickle cell disease. So what are the barriers? What are the problems? Well, there's a large patient population in certain areas with minimal doctors. Seems like the theme of the day is geography. And for South Carolina, it's a lot of poverty and a lot of rural communities. And there are, of course, more pediatric doctors, but there's many more adults living with sickle cell disease. And there's a significant lack of disease-specific education. And it's getting worse because there's less physicians getting the necessary training. A lot of our adult physicians who are going into hematology-oncology get really excited about those oncology paychecks compared to the hematology paychecks. And there are not a lot of people like me available to train these physicians, to get them excited about sickle cell disease, to help them understand why I do think it's such an amazing opportunity as a physician to work with a chronic disease population that you can see live long and live better. Of course, pain is a huge problem, and doctors get very, very frustrated by pain, and so do nurses and social workers, because they can't measure it. They can't wrap their hands around it. They can't see it. You can only measure pain in what the patient tells you it is. And that's a very hard concept for all of us who've been science and math majors our whole lives, that we can't quantitate something without a patient's help. And finally, there's stigma, and the stigma is getting worse and worse as the opioid epidemic gets worse and worse. Because now suddenly our patients are being forced to decrease the amount of medication they're on. And while I do think that opioids are a terrible medication and we need alternatives, until we have them, you shouldn't really try to fix what's not broken. And what I mean by that is I have individuals who've been on very large but chronic doses of opioids and not in the hospital for over 3 years, which is fairly amazing. And these are 40, 45-year-olds living with sickle cell disease. But trying to suddenly wean that opioid dose is not going to go well for anyone. So what are we doing about this? So you've heard a lot about this, so that saves us all some time. We've already talked about the amazing things that HRSA is doing to improve care for sickle cell disease, as well as the CDC, who's developing the longitudinal data collection in California and in Georgia. And that's really helping from a data perspective give us a system for long-term monitoring of healthcare. Also looking at reducing transfusion complications and then best practices for hemoglobinopathy screening. The American Society of Hematology, you also got to hear earlier today about the amazing things that they're doing and how grateful we are that they've really taken this initiative in sickle cell disease. NIH has we hope, a continued increase in funding for sickle cell disease. Now, obviously, we're not sure what's happening now, but we're all here and we're all in this city to help make a difference. And I will say in my recent trip to the Capitol, every single person I met with, every single representative from every office, no matter what color the office was, said they were against going down on the NIH budget. And it was a fairly phenomenal experience, and I will tell you, I actually left the Capitol optimistic. So don't despair. We have to increase clinical research. You know, there's been a lot of stigma in teaching hospitals about partnering with pharmaceutical companies. But in sickle cell disease, with the Orphan Drug Act, our pharmaceutical companies are our friends. They're helping develop new medications. For the first time ever as a physician in sickle cell disease, we have to think, which study am I going to enroll this patient on because I have choices? And that means that that patient has choices. And educating each and every one of them about the options that are out there is incredibly exciting. And of course, we have the SCDAA, who's really working to help us with our community partners, improving and strengthening those partnerships between academia, doctors, and the community, and making sure that our individuals are strengthened and advocating for themselves as well. But what I want to tell you is one of the solutions that we came up with in South Carolina, and it's truly the exact opposite of what you just heard. And what I mean by that is we said, you know what, our community outreach doctors, especially in the adult world, don't want to do sickle cell disease. And it's for a number of reasons. One, they have to see a new patient every 10 to 15 minutes. My initial new patient encounters with my adults living with sickle cell disease, an hour and a half. And sometimes that's just the first half of the visit. And so a lot of our primary care doctors, they don't have that kind of time to spend. I don't even have that kind of time to spend. I just find it. So it really makes a huge difference to take these patients out of a primary care doctor setting and put them into a specialized setting. Another thing that we've also learned about individuals living with sickle cell disease, as we've talked about all day, is they need not just a doctor. They need a social worker, they need nurses, they need community health workers, they need case management. They need people better than me to navigate them through the insurance world. I just get mad and hang up the phone, and that doesn't help anyone. So we need to have this kind of environment. So what we came up with was something called SC Squared, Sickle Cell South Carolina, and it's a hub and spokes care delivery model. And it's designed to increase access to care for all persons within South Carolina with sickle cell disease. And it does include both primary and specialty care, and it's hospital-based care. So what I mean by that is I went to some of the community hospitals where I saw this huge increase in acute care and said, I bet you want to reduce that acute care. I bet you want less patients in the ER, and I bet you want less readmissions. They, of course, said, yes, what are you going to do for us? And so we've worked together to create clinics within the hospital structure so that the patients can come to those clinics, and if they need IV pain management, transfusions, or IV other antibiotics or fluids, can get them in that same location. So each of our clinics is being developed with an infusion area, which also helps the patients avoid the ER, which is not only good for cost, but it's much better for patient care. If you can take individuals out of the ER where they're around everybody from flu to cough to who knows what, and bring them into a specialized environment, where they're going to get specialized sickle cell disease care. They're going to get better, faster, more appropriate care. And this approach harnesses our resources of the state. What it does is allows us to use the hospitals that are already there. We don't have to build any new information or infrastructure, and then add technology in. So we've added telemedicine in. We can actually do clinic in each of these places with a nurse practitioner or a physician assistant and me on the other side of the telemedicine. And so what we've been able to do is develop access to specialty care and primary care in the community. So this is what it looks like. It's still in its infancy. We just started the program about a year ago, and as you might imagine, everything takes time, far more time than I have the patience for, quite honestly. But SC Squared is eventually going to be a thing of its own. Right now, the hub of SC Squared is MUSC, where I am located, but the goal is for it to be sort of its own entity. And then we have spokes in Columbia, which is about 2 hours north of Charleston, in Georgetown, which is in the rural PD area that I showed you, about an hour and a half to the east on the coast, in Beaufort, which is what we call the low country, and it's down by Hilton Head. And then our goals are to increase into Florence and upstate. In each of these areas, we have identified a hospital willing to partner with us, and by partnering with us, they have to provide clinic staff, clinic space, nursing staff, and infusion space. The willingness to have their hospitalists and ED doctors partner with us, and the sort of willingness to receive extra education in sickle cell disease. And it's a slow-moving boat, but it is moving through the water, and we've gotten a lot more doctors joining in. And even our ECHO model that we run out of South Carolina not only touches primary care, but spends most of its time on inpatient and ER management of these patients, because right now that's still where the patients are. And while we are trying to get them into our clinic setting, no matter what we do, some individuals are going to be in the hospital, and managing those patients in the best way possible is incredibly important. Over 50% of the adults that come to me who have not seen a hematologist in any recent years are very iron overloaded and usually have some form of either renal or cardiac insufficiency. So making sure that we can improve their care both in the hospital as well as out of the hospital has been very important. So we know that sickle cell disease is a rare disease. It still limits the life expectancy through chronic complications despite the childhood survival and availability of therapies. And at the individual level, it's about where you live. And I made this slide long before we had the geography conversation this morning. Newborn screening healthcare insurance is basically state-based, and it's even more local than that. And insurance may be more available, but it doesn't equal access. You can have insurance, but if you don't have a doctor or a doctor who takes your insurance, it doesn't matter. And the best care often equilibrates to the best advocates. We have to have a shifting programmatic emphasis on building systems, and in this case, we chose a hub and spoke model to provide that enhanced integrated coordination of care. That's it.
It's a challenging position to be in, the last speaker before lunch. So I am going to try to keep my comments as brief as possible, skip through some of the slides that some of my colleagues have touched on the content already. But in the spirit of trying to leave you with some new messages, I'm hoping that what I'm about to present is an integrated model of inpatient and outpatient care that includes the community. It's community in a different way than you've heard before. It's based on comprehensive care, multidisciplinary care in multiple care settings, including home. And looking at a way of using community health workers to extend the work, often a lot of the work that begins in the hospital, into the community. When people talk about transitions of care, usually as a pediatrician, I am thinking about that transition to pediatric focus, to adult focused care. And in the sickle cell community, that's a particularly problematic state for multiple reasons that you've heard of already. One, there's manpower issues, particularly in providers that provide adult-focused care for individuals living with sickle cell disease. But I think that it's also that transition from home to the hospital and hospital to home. And using community-based resources to make those transitions more easily navigated is really, I think, part of the answer to this complex issue. When I started as Chief Medical Officer of the Sickle Cell Disease Association of America 4 years ago, and I've just stepped down in September, so that's why that says immediate past. One of the challenges that I faced is caring for a population of 1,040 kids living with sickle cell disease in Philadelphia, and then trying to extrapolate what I was seeing on a day-to-day basis to solve a national problem. And so what I'm going to talk about is what we've set up at the Children's Hospital of Philadelphia to look at a new model of integrated care, including the community, and then what we have launched on the national level at the Sickle Cell Disease Association of America to address a more global issue. So I don't need to mention that one of the challenges that no one has really mentioned previously is that sickle cell is a complex disorder, not only because that the individuals that primarily have sickle cell disease in the U.S. are people of color. It's complex because many of those people are living in homes that are poorly resourced economically. And that the other issue is that we are in a partnership that varies. The players are never the same. They're in big groups, but the people come and go as stakeholders in the sickle cell community, and that has led to a very fractured community. We have a pediatric model of care, an adult model of care with patients, families, providers, and health systems. We have funding for those in federal, state, and local levels. We have our community-based organizations, and then we have private industry. And all of those stakeholders really make a very, very big impact on sickle cell disease. And the people who are involved in those aspects of our partnered community vary, and that makes it very challenging to find solutions. So we've heard about the increased life expectancy in individuals living with sickle cell disease, in that a newborn born with sickle cell disease today has a 93% chance of surviving to 20 years of age. And that's basically through comprehensive care, parental education on disease self-management, newborn screening. Now children with sickle cell disease are diagnosed at the newborn period. Parents are informed within the first 2 weeks of life, and penicillin is initiated preferably by 2 months of age. And that has really increased the number of children who survive to 5 years of age here in the United States. And then we have transfusion therapy to prevent primarily neurologic complications, because stroke in sickle cell disease used to be the #1 reason for pediatric stroke. Now we have non-invasive assessment tools that can determine which children with sickle cell disease are at the highest risk for stroke, and actually start transfusion therapy before those strokes occur. And so subsequently, we have data in the state of Pennsylvania that pediatric stroke right now, sickle cell disease is number 8 on the list. So we've moved from 1 to 8 through really being able to screen a large number of children with this instrument, transcranial Doppler ultrasound, in order to identify those at risk, intervene, and really make a difference in their lives. We've mentioned hydroxyurea therapy, which is the only Food and Drug Administration approved medication for sickle cell disease, our only disease-modifying agent right now, and then bone marrow transplant, which is a cure. Just to put it in perspective, we heard Dr. Thompson mention this morning, stem cell transplantation is really the only cure for sickle cell disease, but only 1,000 have been done worldwide. And really the reason for that is the challenge on finding appropriate donors for those living with sickle cell disease. So NIH, ASH members, and others are really working towards being able to find donors and individuals living with sickle cell disease that are willing to participate in clinical trials to see if we can use chemotherapy in a way that makes bone marrow transplant safe, using a donor that may not be a brother or a sister. And this is huge. And then we've heard about gene therapy, where essentially the individual living with sickle cell disease is their own donor, but with modification of the cells that grow up to be red cells. And then that's through gene therapy, and then other techniques, gene editing, is really the focus for the future. I want to really address pain and sickle cell disease, because I think that one of the things that we have heard is that there are new partners in our sickle cell space, with pharma actually coming up with new agents, new targeted areas that will be able to be used in order to prevent individuals with sickle cell disease from having pain, or to alter the course of a painful episode by decreasing pain without using opioids. And this is huge. We are now at a point where, when we talked about the AIDS epidemic in hemophilia, we really are at a point where if we have new therapies to address pain and sickle cell disease, it could swing the pendulum into a positive direction. Because right now, the stigma associated with needing opioids to treat pain is oppressive. And the sickle cell community needs new drugs to really help us address pain as an important complication of sickle cell disease. The pain of sickle cell disease has also caused individuals living with sickle cell disease to become isolated. The stigma further isolates these individuals, so that it is not unusual to hear Jeffrey mention today that he was able to go in and out of these communities and not have any contact with someone else living with sickle cell disease. Dr. Bridges and I took care of a young woman who went back and forth between Philadelphia and Boston, where she was at Harvard, in order to get transfusions. And she came home every 4 to 5 weeks because her insurance company wouldn't cover the cost of transfusion therapy, even though she was able to see Dr. Bridges. But she was isolated in the sense of there was such stigma associated with sickle cell disease. She was worried about what that would mean in future jobs for her if individuals realized that she had sickle cell disease. So individuals with sickle cell disease are isolated not only because of the stigma, but because of the way that the health system has forced them to manage their own illness. Sickle cell is expensive care. When you look at the numbers, and these are 2004 numbers, you can see that there's millions of dollars in going into the care of individuals with sickle cell disease. And this is primarily related, 80% of these costs, to inpatient stays. So if we could figure out a way to transition the care of those living with sickle cell disease out of an expensive care environment into either a day hospital or a home care setting where therapies that can prevent or treat pain can be administered in these different cost settings, I think that this will also be something that swings the pendulum into a more positive direction. The other issue is that many, many individuals with sickle cell disease who have pain need to seek care in emergency departments. And in the pediatric community, we have really done a great job of making sure that individuals with sickle cell, when they come in, are prioritized to get immediate care, triage at a level 1, but that does not translate into adult care. So many adults wait hours upon hours in emergency department settings, waiting for either appropriate analgesics or a quiet environment in order for them to fully recover from their care. And again, it's a more expensive area, but if you can see across the lifespan, it is heavily utilized by individuals living with sickle cell disease. So what's the solution? Well, a lot of the research in sickle cell disease has been done in pediatric age groups. So now we know that we can prevent strokes from happening. We have hydroxyurea that can prevent pain and acute chest syndrome. We really have shown that infection prevention through penicillin, through vaccines, can improve the lives of those living with sickle cell disease. So we've really gone from being reactive in our care for children with sickle cell disease, wait till something presents as a problem and then try to fix it, to trying to fix it before it becomes a problem. But that takes a village. It is a lot in order to get that young person living with sickle cell disease at age 2 to get annual TCD screening. That individual has to come to see me 3 to 4 times a year just for regular care, so I can make sure that I am identifying problems early in their stage before they become more of a problem. So that individual sees me 3 to 4 times a year. That doesn't count for the primary care visits that they need to go to get their immunizations, their flu vaccines. They need to go to the dentist. 25% of individuals living with sickle cell disease have another comorbid state. It's usually asthma. That care needs to be done as well. So if you look at all of the times a 2-year-old needs to come to the hospital to get sickle cell care, imagine what that looks like at 22. So we have really had to build a system that enables us to help address the social and the barriers to care, as well as the coordination of care that's needed to get all of these things done for our patient population to stay healthy. And this is in the setting of a high no-show rate. Acute pain managed in the ED requiring fast triage. I'm telling my ED docs, you got to get pain medicine in within 15 minutes. And I'm going to measure it to make sure that it happens. unpredictable lengths of stay. Why not set the bar so that you can say any individual living with sickle cell disease should be able to be considered to be on a medication by mouth within 24 hours because you've done such a good job at addressing their pain that that's the time that they should be able to be considered to go home. You have to think about how we can prevent readmission rates. We have to make sure in my hospital, if any discharge happens after 6 o'clock and that individual needs a pain med, it's not going to happen. Because the pharmacies in Philadelphia do not stock opioids for fear of theft. So my patients can only get their opioids to go home with from my hospital. And if my hospital pharmacy closes at 7 o'clock, they're done. So we have built systems that we'll talk about that have addressed some of these challenges that we know are within a pediatric setting, and if we can figure it out in a pediatric setting, then maybe we can translate some of the solutions into an adult-focused care setting. And then we've already talked about the stigma associated with acute and chronic pain, the isolation, and the challenges related to opioid prescription monitoring. Right now in Pennsylvania, they have an opioid prescription drug plan that is wonderful in the sense of it is addressing a huge epidemic in Pennsylvania about addiction to opioids in all Pennsylvanians. But it is particularly impacting my patient population who needs these opioids for good care and to treat their pain. So we have a system in place now before you can even write a prescription for anybody that's being discharged from the hospital or in the outpatient setting. You have to query a database and then review all of the medications and get the parent to sign a consent form before you can even write the prescription. All of these barriers, who wants to sign up to be a doctor that provides care? A nurse practitioner, a nurse, a social worker, when I'm asking you to not only work hard as a part of what you need to do to keep a routine individual living healthy, but now with a chronic illness and a chronic illness with all these barriers, it's a challenge. It's difficult to get people to come in. So what's the right care model? It's got to be multidisciplinary. It's got to be comprehensive because I showed you all of the things they need. They have to do all this, plus I expect them to go to the dentist once a year, right? So they got a lot of work to do. And because of the isolation, because of the community that individuals with sickle cell disease have to live in, behavioral health issues are often problematic. So we have to have integrative behavioral health. So when they're coming to see me, they can see a behavioral health specialist at the same time. And that same behavioral health specialist, yeah, they need to be there so that they can go over when they're inpatient and see them when they're inpatient as well. Then we need to figure out support for that individual's academic and vocational goals. When we're talking about graduating from my program, yeah, you don't have to just graduate from a pediatric to an adult-focused care program. You have to show me that you're going on with your life. So you're either going to college or you have a job. And it's my team's responsibility to make sure that that can happen in the context of a chronic illness. And then you have to have an integrative health component because guess what? I respect that not everybody wants to take a pill. So if you want to do acupuncture, if you want to do acupressure, if you want to do yoga, if you want to do guided imagery, then I have to make sure that there's some other option other than an opioid or a medication to address that. And then I have to have the community-based component. Because it might be one thing standing in front of me for 15 minutes to try to figure this out, but I have to have a team that's going to make this work for you on the day-to-day. And that's a community health worker, an education specialist. So guess what? This is my team. I have one program director, that's me. I'm responsible for 1,046 kids that are being provided care in 3 different hospitals that have the CHOP logo. I have a nurse coordinator, and I have 2 nurses, one that is specifically addressing long-term therapies, hydroxyurea. Of my 1,046, 650 have the SS type of sickle cell disease, 115 are on transfusions for stroke prevention. That number is coming down because we have a new study that shows that a lot of those, it's safe to use hydroxyurea. And now we have 498 on hydroxyurea therapy. And without HRSA funding, it would have been 200 less. So we'll talk about how that made a difference. I have 3.5 social workers. 1 social worker is dedicated to 0 to 5-year-olds, a second social worker to 5 to 22-year-olds, a full-time social worker just to address educational needs, and a half-time social worker, 0.5 FTE, just to address insurance issues. All right? I have a behavioral health specialist. I have a hydroxyurea educator that is also the medical officer of our local member organization, Sickle Cell Disease Association of America. She comes in 3 mornings a week and educates individuals, families on the benefits of hydroxyurea. And really through that HRSA funding that is supporting that work, we have added 200 additional individuals on hydroxyurea within the last year. We have a community health worker, and that community health worker is responsible for going back and forth with the schools to make sure that there is a IEP, that there's a 504 plan, that we're really working towards graduating this young person out of our program, not only into adult care, but into a career. We have 3 nurse practitioners because we have a hematology acute care unit that sees individuals when they have pain and fever. And then I borrow all of the rest of those services from the hospital. Look at all of those other resources. So if this is what individuals are getting on the pediatric side, and in order to do that, we have HRSA funding, we have state funding, and I have 3 health insurance providers that are helping me fund the community health worker, the disease educator, and the behavioral health specialist. So if we're going to do this and we're going to duplicate these systems of care on the adult side, it is truly going to take a village. And you can see why individuals living with sickle cell disease are so hesitant to go into a new system, not only because it's just that they don't know the doctor. Because when they're coming back to visit me in my pediatric program, they're not just coming back to visit me, they're coming back to see the social worker, the nurse, everybody that they grew up with, the behavioral health specialist. So it's about leaving that system. So we need to focus on building an adult care system for adults with sickle cell disease that's very similar to the pediatric infrastructure. And the only way to do this across the lifespan is by bringing the community into the hospital and the hospital going back out to the community. So having our hydroxyurea educator be the medical director at our local SCDAA means that when there was free dental care that was provided in the community, SCDAA brought that information into us. We got vans and we shipped the kids out to free dental care. You have to be creative, but I think that you can make the hospital a beneficial place if that individual is leaving the outpatient clinic in the hospital empowered. They have new information, they have seen all of their specialists in one day. I don't want my kids to miss more than one day of school, so we have a care coordinator that makes sure they can see their TCD and everything in the same day that they're coming to see me. The pulmonologist sees them the same day for their asthma. The general pediatrician sees them the same day for their shots. It takes care coordination, a lot of work, but it's doable. And then SCDAA's Get Connected registry is the backbone behind this. HRSA money allowed us to hire 42 community health workers and train them to get individuals living with sickle cell disease into a registry, a patient-powered information sharing registry whose sole purpose was to see where those individuals were and whether or not they were getting good care and whether or not we could send them information about their health care. And everybody said it could not be done. We had so many naysayers in the room saying, this is pie in the sky, you all are community-based organization, this is never going to work. But in reality, if we can get this to work and sign and register kids in Get Connected in the pediatric age group, you can follow them across the lifespan. You don't have to worry about losing them. They will be within this database. So we started this project 2 years ago, established a network to distribute information, establish a mechanism to support care coordination, and to develop an online community for information sharing and psychosocial support. We have email blasts that go out about, are you ready to go to college? This is what you need to do to go to camp. What is it like living with sickle cell trait? What are the problems with hemoglobin A1C testing in diabetes and sickle cell trait? All of that information goes out in email blast. And ultimately, we'll be able to survey those individuals and have them let us know what we need to do to better serve them. So when we started this, obviously, it was bare minimum. We had the HRSA grant, we educated the community health workers, and in less than a year, we now have 5,526 in Get Connected. 4,523 of those are individuals living with sickle cell disease, children and adults. I can tell you how many know about Hydrea, I can tell you how many are in a medical home, and I can tell you how many have had contact with their community-based organization and their healthcare system. And that is primarily targeting non-academic centers. We asked our member organizations to go out and not go to clinics, to find individuals who were not active. So this is the hardest work, and they did it in a year. The cooperative study for sickle cell disease got 3,968 individuals registered, and it took them 3 years to do it, and that was in academic centers. And yet community-based organizations went out and registered over 4,500 in a year. We need to use the community. We need to find a way to bring the hospital and the community closer together and more interactive. And I think this is just one of the ways to do it. This is my last slide. So the solution is to find integrated models of healthcare, systems to track patients, track healthcare utilization, and identify service gaps. We still need disease-modifying therapies and a universal cure, but without good ways of communities working together to find data, to build policies that are informed with good data and reflect the chronic disease illness population needs. And thank you. That's it.